ERISAfire is the special ops of health and welfare employee benefits compliance, serving employee benefits brokers and their employer clients. We offer you peace of mind that your compliance risk is managed holistically, even when the benefits environment is ever-changing. We back our work with a quality guarantee and the assurance that our attorneys and paralegals will catch what others miss. We walk alongside you with continued compliance support to protect your business and help you succeed. Here's some of our practical, actionable guidance. Please enjoy this video from the ERISAfire archives.
Well, welcome everyone to the 6th ERISAfire COVID-19 Town Hall. This is the grand finale of our 6-week Town Hall series. And I'm going to start with just a few housekeeping items before we get to our topics about what flattening the curve really means for business and how to safely return to work. If you have any issues with audio, we recommend dialing in by phone. The number is here on your screen, and I'll also share that by chat here momentarily. If you could click on Manage Participants, and then you'll see next to your name, there's a button for rename. We'd love to be able to call you by name when you have a question. And if you could put that in there, it will be much easier to do so. For any questions that you have, if you could enter them in the chat, the default is to everyone, and that is fine to share with everyone. And I will go ahead and call on people and unmute you at the time that it's your turn to ask a question. For those of you who haven't had an opportunity to receive it, we talked a little bit about the beginning when we were talking about furlough, that David has authored an article with Bloomberg Law about furlough as employer response to pandemics and economic crises. If you would like a copy of that, please private chat me in Zoom, and I will, with your email address, and I will send it to you. So for those of you who do not know David or are new to joining us, David Lefevre is the founder of ERISAfire Benefits Compliance Solutions and managing attorney of Lefevre Law PC. He's been an employee benefits attorney for 13 years, and his practice focuses on assisting clients in complying with ERISA and other employee benefits laws pertaining to health, welfare, and retirement. Over to you, Dave.
Good morning, everybody. Today is Tuesday, April 28th, 2020, 99 days since the first reported case of coronavirus in the United States. We have a great program for you here today. And just a few things at the top of the hour. Because we want to get to our guest here very, very soon, we're going to cut short some of the news and regulatory information at the beginning so that we can get straight to the heart of the matter. That is certainly very timely in light of some state announcements. Just a couple of things. First, I wanted to make note that the agencies fortunately have slowed down their editing of the FAQs released in response to Congress's passage of the FFCRA and the CARES Act. There was a new piece of legislation geared toward providing more funding for the Small Business Administration's PPP loan program. But as far as developments with respect to paid leave, sick leave, and other requirements, those have stayed relatively stable. Those have stayed relatively stable, which is good news. So the other item I wanted to make sure that we talked about and mentioned was that as the economic effects of this pandemic are felt, and I would submit to people that we are just beginning to really feel in broad strokes the effects of this. Certainly, and this is not to discount those who have been furloughed or laid off already, particularly in those in discretionary spending sectors. This is not to discount them, but the broader economic implications are probably still yet to be felt. And as a result, businesses are going to have to make some very, very difficult decisions and make excellent use of the resources that they have. Liquidity is probably going to be an issue. And so I wanted to make sure I mentioned one of the tax advantage programs that is available, called a supplemental unemployment benefit plan. I mentioned it very briefly a couple of weeks ago and just wanted to recap on that real quick. It's a tool that's been around since the 1960s, actually, but it's not been used a whole heck of a lot for various reasons. But now, especially for employers that have had severance programs in the past and are looking for ways to make the best use of those dollars, implementing something called a sub-plan or a supplemental unemployment benefit plan is a tax-advantaged way to do that. There are compliance issues, or not issues necessarily, but just compliance checklist items that need to be addressed. It is a tax advantage program, and so you do have to have a tax qualified plan document. It is an ERISA welfare benefit, and so there are some regulations that need to be followed in implementing one. But the primary advantage of these supplemental unemployment benefit plans is that you can essentially coordinate your severance program with state unemployment. There's some hoops you have to jump through to do that. What you can effectively do is reduce your severance costs by upwards of 30 to 45% by coordinating and essentially offsetting your severance program with state unemployment. So employees essentially stay the same in terms of what they would receive under your severance program, but you're getting essentially the state to pay for some of it, and avoiding some federal payroll taxes along the way. I would not recommend doing these without counsel or without somebody who knows a lot about how to do these. We have experience with it, and there are some do's and don'ts, and there are some variances from state to state. So just something to keep in mind as we start to feel the economic effects of the coronavirus pandemic. So those are the only news items we wanted to cover here at the beginning of the hour. Before we get to our guest, though, we want to, we first have a word from our sponsor.
Hi, I'm Aaron Richards, Solutions Navigator at ERISAfire, and I was once told I have a face made for the radio. ERISAfire is the special ops of health and welfare employee benefits compliance. We'd like to thank you for taking the time to attend our COVID-19 Town Hall. Your dedication to educating yourself during a crisis shows your genuine concern and compassion for your employees and clients. For that, we thank you. During these unusual times, and all the time, ERISAfire offers you peace of mind that your compliance risk is being managed holistically, even as the benefits environment continues to change. You and all of your compliance projects are protected with a quality guarantee and the assurance that our staff of attorneys and paralegals will catch what others miss. And we will personally walk alongside you with continued support because our mission of service is fulfilled in your success. So whether you've had a tricky compliance question, need annual ACA reporting or Form 5500 filings or a plan document update, we're here for you. For more information or a quote, contact me at aaron@erisafire.com. Now back to our regularly scheduled program.
Thank you, Aaron. All right, so without further ado, I want to introduce to everyone Dr. Kenneth Wells. All right, Dr. Wells is a trusted advisor for executive and corporate health management. His current work focuses on strategic advisory services for healthcare cost containment and risk management, including guidance that he provides to benefits consultants, insurance brokers, and their business clients. One area of innovation is Dr. Wells' work on medical tourism and the development of domestic and international centers of excellence. For more than 20 years, his knowledge and leadership has produced substantial savings and enhanced efficiencies for Fortune 500 companies in various industries, including energy, oil and gas, insurance, aerospace, and others. He's consulted with major insurance companies, hospitals, NASA, and a leading railroad in their efforts to develop innovative health services to improve quality and reduce costs. One of those projects, I might add, included work on the International Space Station, not literally on the International Space Station, unless Dr. Wells failed to tell me something. But Dr. Wells actually helped develop some of the exercise equipment for the International Space Station, which is incredible. He frequently lectures at universities and health conferences on the topics of healthcare policy and corporate health cost containment strategies. He served 12 years in the U.S. Army Reserves and the Texas Army National Guard, where his duties included commanding an aviation medicine facility and directing training for emergency medical evacuation and battlefield contingencies. He was previously named the U.S. Army National Guard Flight Surgeon of the Year. Dr. Wells, welcome to the program.
All right, thank you, David. Good to see you again.
Likewise, Doc. So there's a lot that's been happening here, even just in the last few days, but I want to kind of back up real quick and talk about something that seems like eons ago, but was really maybe only a couple of weeks or 3 or 4 weeks. And that was this concept of flattening the curve. And I'm gonna share a graphic here real quick that made it throughout the news media. And let's see, there it is. Okay, so this one, in fact, was actually from the New York Times, but was published elsewhere. And this is the graphic everybody sees when we start talking about flattening the curve. Of course, there are 2 curves here, right? We've got one without social distancing and other protective measures, and then one with social distancing and protective measures. Oversimplified, obviously, because you can take different measures for different amounts of time, and different places can see different effects. So it's a little oversimplified, but this is flattening the curve. And so I'm just thinking less in terms of businesses and more in terms of just our everyday lives. We got this information and these suggestions that we need to exercise proper social distancing in order to flatten the curve. Okay, all right, no problem. And so I think we've done that in many parts of the country. And so we are now past this big hump, the big red hump, and everything's going to be fine, right? Like it's over. Yeah?
No. Let's take a step back, as you say. Now, the entire premise of this was, if you look at the red curve, what we were trying to do was to avoid that. Now, if you look at the curve, there's a blue line that is the blue dotted line that passes through that curve, and it says healthcare system capacity. Now, that capacity is significant. And if you look at the red curve, the whole premise of this was, if that top of the curve crossed over and or above the dotted line, the healthcare system would not be able to manage the number of cases that it was going to be asked to take on. And so the number of deaths related to that and or extreme morbidity, mortality issues related to that would exceed the ability of the healthcare system to manage it. So the discussions, and we'll use New York as an example, where New York was, the number of cases that were coming through were rising very, very rapidly. And the concern in terms of asking for respirators and for people to come in to help was because the concern at that point really was focused around exceeding the capacity of the system. And if you don't have enough respirators, you don't have enough intensive care units, you don't have enough nurses, you don't have enough doctors to manage this, then in fact, that people are going to die. That was the significance of this. So back in early March, end of February, early March, the CDC recognized that this was a huge challenge, and so came out with the issue of trying to flatten the curve through social distancing, PPE, and other measures that many of us have become intimately familiar with. So we talk about flattening the curve, and that moved us to the blue curve. Now, there's something that's really interesting about this that people very often miss, and I think it's significant because it plays into what's going on right now as we're trying to work to get back to work. When you flatten the curve, and what I'd like your viewers to imagine is, if someone put the palm of their hand on the top of the red curve and started to push that curve down, push the top of the curve down below the blue dotted line, what happens to the base of that curve? Well, it expands, right? It gets wider. So the total number of cases in actuality doesn't change. And as Dr. Fauci, you've heard him say, the virus is going to do what the virus is going to do. So the cases haven't changed. But what you've done is you've exchanged a peak for a lower curve, which allows the capacity to manage this. And if you look at it, we have been successful in that regard. So, and I would also like to give you and your viewers an example of cases where it worked that well. In Italy, for example, they were not able to push the curve down. And so you ended up with a huge crisis there in terms of the red spike that you see here of the without protective measures and just, going through. But in other areas, Houston in particular, have done a very good job here where the curve was able to be pressed or depressed. And so it means, though, that what you're exchanging is the peak for the base. And so the amount of time that this is spread out over is going to be much longer. So where Italy had a number of cases, a very high number of cases that occurred in a very short period of time and exceeded the capacity of the system to manage it, what we're having here in the US is a longer curve, but with the ability to manage through that. So that's the significance of this curve. And people tend to focus on just one side, but not the other. We're now at or about the top of this blue curve, but remember the base is wider, so the amount of time to recover is going to take longer.
And I think that's really important for people to realize, kind of putting our business hats back on, that one of the effects, I won't say downside or upside, or just one of the effects is that the amount of time that protective measures, according to this chart, are going to be needed is looking at roughly just over double, maybe even 2 times as long as if. So we traded a spike for a much longer period of time, requiring that changes to normal, that there be a new normal, essentially. And so even as we're seeing places where there were spikes returning to recovery, and I'm thinking primarily Europe, and maybe to some extent places in Asia, where there was a spike, they might be returning to picking up the pieces and recovering, but we can't necessarily just follow the same timeline. Well, Italy is, I heard somebody say this the other day, that, Italy is, 3 weeks or a month behind us. And so the implication being we can do whatever Italy is doing 4 weeks from now. And I don't think that works because of what flattening the curve really means.
Right. Yeah. In essence, as you said, we just exchanged that peak or the severity for a longer base. But the number of cases and the ability to manage through that has increased. But it's important to recognize that we buy time. And by buying time, it allows for the onset or the development of technologies to manage this and perhaps manage it more effectively or more efficiently. And there is value in that. And so as we look at testing now, the ability to test, the quality of the tests that we're now using is far better than it was just a month ago.
Oh, that's an interesting implication. Okay, so testing in the United States, pretty widely publicized, was abysmal, and to some extent still is. And so, on the one hand, I look at that flattening the curve and I'm like, I got to do what for how long? But on the other hand, it does buy us time, and maybe, particularly for medium-sized businesses or even large businesses with smaller margins that may not be able to pay $1,100 a pop for a test. If we are able to lengthen things out, technologies we can develop some efficiencies and perhaps maybe bring that dosage cost down and have wider spread testing.
Absolutely. As we talk about the testing, and it was interesting. I was just, you mentioned $1,100. Well, I'm working with a vendor just this morning. They're testing now. One company that I worked with spent, just for the collection part of this, just to have someone collect the sample, and this was a sputum sample, they charged them $1,200 per person, which was absolutely ridiculous, but they didn't have a choice. it was an essential, it was an industry and involved in an essential field. And so they had no choice other than to test their people. But forget the test itself, just to have someone go in and stick a Q-tip in someone's nose or back to the back of the charging $1,200. That is now down all in at this point at $1,200. I'm sorry, at $125. So it's substantial, reduction.
90% reduction.
So you can see things have changed. But in addition to that, there's a move as well to going to antibody testing, and timing is everything. I just this morning underwent an antibody test. Was meeting with a client, and we were testing their people with antibodies. The new antibody test is $25. So it gives us much more information, much better information, and the specificity around this and sensitivity on this particular test is actually superior to what was there before. So, we're moving in the right direction, but we certainly need much more testing in order to be efficient and to be able to help manage through this, because we're lacking in data, and that's why we're seeing kind of this schizophrenic sort of approach toward the management of this, where you're hearing one thing out of the White House, something else out of Austin, and then here locally, you'll hear something totally different, where the employers very often feel that they're left to their own devices in terms of, okay, well, what does this mean? How do we manage through this?
So let's talk about that real quick, because we do have, in the last 48 hours, quite a bit of activity on this front. We've got a number of states that have been talking for a little while about opening up. The Western states, California, Washington, Oregon, Nevada, and recently Colorado kind of formed a pact with one another to coordinate their reopening efforts. New York, Governor Cuomo has started talking about a sensible plan. When I say sensible, I mean there's some science behind it, and there's details to what it is that the state of New York is doing. Then you've got kind of a third branch, if you will, or third segment of the country. And I'm going to say, Texas, Oklahoma, Georgia, Tennessee, and some other southern states that have a little bit different approach. Governors announcing different things. I understand that I think it was Tennessee, restaurants already were allowed to open. Georgia, for sure. Earlier, I think it was yesterday, said restaurants could open. So you got states saying, okay, we're open for business, but a state governor is not running my business. He's not directing my employees. So, what am I as an employer to do when I've got, kind of these mixed messages that, the pandemic is bad, but the pandemic's not really that bad. So what am I to do? Do I, as a business owner, have a responsibility or even a liability that is kind of separate and apart from what a state governor thinks I should do?
And I think that you put your finger on the crux of the issue. In terms of getting the guidance from, whether it's the federal level or the state or local, it has been all over the place. And particularly for the smaller employers, it's just very difficult for them to figure out what to do. They may not even have, and they may not have the capability or the resources in order to do this. But even for the larger employers, many of the ones that I'm working with, they're faced with the same questions. How do we safely bring someone back? And to some extent, a lot of that information is not forthcoming from the government, to be honest. Most of the companies that have been successful in this, and the companies I've been working with who've been successful, have taken the position, okay, it's our responsibility. We're going to have to figure out how to do this. And so we've looked at other industries that have been successful or at least are doing something. And so the issue of social distancing, and we can talk about that for a second. How do you do that? Well, how do you affect a 6-foot separation in a space that was designed for maximal density? From an efficient
cubicles, right?
Yeah,
the whole point behind cubicles is to get as many people into as small a space as possible.
Exactly. And so now we're saying, well, that's not going to work. So how do we do it? One of the quick things what we're doing with a number of companies is, saying if you're going to bring people back, bring them back in phases. 10%, 20, not more than 20% in any one tranche. to the extent that you can screen these people as you bring them back in, you can also reduce and mitigate some of the risk around that. So the testing piece, and you've heard a lot of this in the media, actually is critical to successfully bringing people in. By way of example, if you can screen people for antibodies and identify who has the antibodies. Now there's some debate as it stands right now in terms of whether it really does offer true protection going forward. But unless this virus acts in a way that's totally different from any other virus, we know that there should be some protection that's offered.
Right. So let me jump on that just real quick, because I did see in Washington Post, I believe, and a kind of a reprint of sorts and then commentary on some information from the World Health Organization.
Exactly.
The headline was, there's no evidence that getting it once provides you any protection. I'm oversimplifying it.
And that is a true statement. But
the implication of the article, the implication was that there was the opposite conclusion, right? And as kind of data nerds, you and I know that stating there is no information to suggest this does not mean the opposite conclusion, but that's not what most people are going to think.
Absolutely, yeah. So, but let me give you where this falls out. I mean, it's responsible for the World Health Organization to come out and say, hey, look, we don't want anyone to get a sense of false security around this thing, right? But so we can act responsibly, or you can use it in the other way and say, oh, it doesn't matter because you can get this and it still doesn't offer, so we're all going to die. That's not what's being said. Let me give you an example that perhaps others, many of you who've done travel could relate to. If you take, for example, the hepatitis vaccine that people who, if you're traveling to Mexico or other parts of the world, you want to get a hepatitis A, B, and even a C type vaccine to offer you some protection against foodborne, infections from viruses. And even if you work in a hospital setting, you want to have titers for hepatitis because people could come in and you could pick up hepatitis from them. So it's a very common thing to do. It's given in commonly we will have to give 3 injections over a period of 6 months to make sure that the titers get to a level that offers adequate protection, okay? So that's the issue.
By that you mean antibodies or?
We mean antibodies, yeah.
Got it.
So let's say in your first encounter, you might get antibody levels that will take you to 50% protection. That's better than nothing. I mean, that's good. That's good protection. The second one may get you to 70, 75, 80%. And then your third one would get you up to 97, 98% protection. You see, so you have to challenge the immune system. We don't know yet with this virus because it hasn't been around long enough. And the whole concept of calling it a novel virus is correct. It's novel because we haven't seen it before. We are learning on the fly as we go with this. So you'll hear different stories that sound as though they're totally opposite, but it's simply because the information that we're trying to, our learning curve is very steep on this virus, and we're to a large extent we're learning as we go. But we are learning a lot. But I want to make sure I talked about that the report out of the World Health Organization, because they're not saying that it has no, that there is no protection. They're just simply saying if indeed you get reinfected or someone appears to have symptoms again, it doesn't mean there's a failure. It just simply means that this could happen. And there are a host of other viruses that the same thing could happen to.
Typhoid fever, for instance, you can get multiple times. In fact, actually, it's worse the second time than it is the first.
Or for that matter, the virus that causes chickenpox causes shingles. Same virus.
Right.
But if you get a booster later in life, the odds of you developing shingles is lessened.
So we're operating with not a lot of information for understandable reasons. It is a novel new virus, but we are operating on at least some assumptions based on other coronaviruses and I think one estimate I saw said that there's a good likelihood, however you want to define that, that you get about a year, you might get about a year of protection if it behaves like other coronaviruses. We're not going to be able to sit around and wait for all the data to be done, to be collected, and the research to be done, because we're not gonna be able to do that. People are getting antsy enough as it is, and are going to start opening up kind of no matter what. So we have to operate on some sort of assumption and do something to keep people working, or else all of society breaks down. So one of the things you mentioned, I'm just kind of want to break it down into phases here, into steps. We got, kind of one is to bring people back in phases. And for each business has to decide for itself what those phases look like and who to bring back. Maybe keep your remote workers who are doing just fine at home, keep them home. If you got to have people on site, you start working with them. Screen as they come in. And when you say screening, we've got employers of all different sizes from coast to coast here with us. So what do you mean by screening? Are we talking about an antibody test that hopefully we can be gotten for a couple $100?
Right. Well, I'll tell you, it's never that simple, right, David? So no, it never is. So you had the PCR testing, which is the ones that you heard a lot about, which were the ones of the more expensive ones, which principally were used in a hospital setting to tell us whether or not someone who comes in with what we thought to be the classic symptoms at that time, high fever, the dry cough, that sort of thing, that if they were shedding virus, you could swab the back of their throats, and now it's moved to a sputum test. That's quite effective. But you're looking for active viral particles in this case, okay?
And that's the positive, negative for the presence of the virus, active virus.
At that particular time, right. Now you do have carriers, or people who could have the virus but are asymptomatic, different category. But that we have to recognize that they're out there. On the other hand, you have the antibodies, which would be for people who've been exposed to the virus, their body has fought the virus and successfully gotten over it. And in that case, they successfully have gotten over the virus, and their body is now producing these antibodies to offer future protection against a reinfection. All right. So what does it tell us? In the antibody screening or testing, you get what's called an IgE and an IgM. The IgM, you'll see, which are two curves, and there's a cassette and there's two little dot lines, but it tells you where your body is in terms of the exposure to it. If you have both the IgM and the IgG, that means you were exposed at some time in the past, and you now have good antibody, generally good antibody to manage through this, we think, okay? And that good, I had to put in quotes, because again, what we just talked about.
Right, yeah.
But the IgM is a very short window. It means that you were exposed within the last 3 to 5 days, okay? But it's a quick spike. If you see that and you say, well, they were exposed within the last 3 to 5 days, we can watch this person. But it does mean that their body is fighting it. And then if you test them again and you see the IgG has gone up, then you can say, okay, they're on it. But what that means is that particular group, people who fall into that group of antibody positives, can be returned to work. They still need to wear protective, mask and protective social distancing, all of those sort of things. But they're in a different category than someone who is negative, because they are that negative group, whether they're negative on the PCR or they're negative on antibody, are still at risk. And remember, what we're trying to affect here is this concept of herd immunity, right? So if you can create a herd, and that's what I was doing earlier on with some clients that had essential workers. That, we had some that had to go out to a drilling ship just off the coast of South America. And the last thing that we could tolerate in that situation was for them to have an outbreak on that ship.
Right.
Because it would shut in their operations, and these operations are well over $1 million a day just to keep the ship going, right? So the cost is such that you can't tolerate that. So you build in a model that says, we're going to create this herd, we identify these people, and we measure them, we follow them, make sure they don't have, and then that group goes. But they all stay together. So if they're all negative, and you don't introduce anyone from the outside to them. We're now trying to do this in reverse, bringing people into a workplace. And it's much more complicated.
So for, let's say companies outside the Fortune 500, is there a vendor, or how do employers go about screening if they're of a middle market, or a lower end of large market, a few thousand employees as opposed to hundreds of thousands? How are they to source these kinds of tests?
Most trade groups and industry groups have done some work in this space to look at what they need to do for their workers. So, for example, if you look at the grocers group, right? We've all been to the grocery store, over the last 2 months. And so we see, and they've been pretty consistent. Whether you go to HEB or Kroger's, they're all doing the same thing in terms of putting these shields up now, and building the 6-foot separations and the marks on the floors and the mask and that sort of thing like that, in a way to try to protect their workers. So I generally recommend going back and looking at what your industry is doing, what their recommendations are. There will always be certain commonalities around it, but it always generally is based around this issue of the social distancing, the use of masks when you're in close proximity, and then making sure that the testing, when it becomes available, that you avail your people of that to allow them to find out where they are on this curve.
So I'm thinking of, your let's say average size employer, 500 or 1,000 employees or so, or even south of that, sourcing their own screening tests, antibody tests. That's probably going to be very, very difficult to do, especially at this point. So
right.
And I'm going to admit, I'm asking you to read a little bit of a crystal ball here. Is it conceivable or reasonable to think that the major carriers will publicize something about the availability of antibody testing, or will it be distributed to our family health practitioners? Is there some hope that there will be kind of a more widespread antibody testing so that people can get their antibody passport, if you will?
That's the honest answer is TBD, right? To be determined. Now, early on in this, the White House promised that anyone who wanted to be tested could be tested. Unfortunately, even from a public health perspective, we are woefully inadequate in terms of the amount of testing that really needs to be done in order to make these educated guesses, if you will, in terms of what the true penetration of the virus is within the communities and that sort of thing like that. So it makes it more difficult to build that scientific modeling around with the level of precision that people are asking. And it's frustrating. But I think it falls in that category of lessons learned, and that, we know that we need to do this, and that focus perhaps was in the wrong place, and we failed to follow through in some areas that really needed to be. But I think you'll see now that there's this scramble, if you will, to make these kits more readily available, to get them out there, because I think the general public understands the importance of the testing, and knowing so that you can figure out what to do, what your role is in being able to protect not only yourself, but your family, your coworkers, your friends.
Yeah. So the second step that I jotted down in terms of bringing people back to work, bring back in phases was number one, and screen. I would imagine screen. We've talked a lot about antibody testing because it's been in the news a lot, and it's fast moving in terms of developments. But there's also screening for symptoms that you don't need a fancy test for. Screening for fever. Looking for sweating, looking for coughing, things like that, and saying, hey man, I appreciate you coming in, but you probably need to go home, right? So screening for symptoms, I would imagine, is also on the list.
And that is very common. So there are ways that either in some instances, people are posting an individual with a digital thermometer, the infrared thermometer, we take temperature off the forehead. Some are done in one instance, I have a client that is kind of like at the airport, right? So they walk through, there's a video using thermal imaging cameras. They can look at people as they walk in the door. And this guy's got a heat signature, pull them off. And then they will then undergo secondary testing. But another part, though, that falls into the second category that we didn't talk about, that I think is important, is you have to engineer your office space to allow for this. So I'll give you a real life example. You take high-rise office spaces. The office building I was in this morning. How many people can you put on an elevator?
Oh, Lordy.
And maintain social
you could get 10, 15 people on an elevator.
Yeah,
easy.
but if we're trying to maintain social distancing of 6 feet, how many can you put on?
Probably 4, maybe 5 if you go one in each corner and one in the middle. You can maybe get 5.
So it's actually more like 2.
Oh boy.
Standard. So, so these are the sort of things that people really are saying, well, we got to get back to work. But from a practical standpoint, and you think about it, if you try to bring back your full workforce, or even 20% of your workforce, and you had to get them into, and you're in a high-rise facility, and you're maintaining social distancing, how long do you do it? So now we're talking about phasing them in over time and changing their work schedules to be able to access the office.
So we're going to call this one Rethinking Logistics.
Absolutely.
And so we're talking not just in terms of physical space. Well, maybe we go every other cubicle or whatever the case may be, but also time. Because if you can only get people into the building, if you followed the advice of our HIPAA webinar and had a choke point for people to check in because you wanted to make sure that all your PHI, well, you've just created a choke point for everybody to interact with one another. And so maybe you got to open up another door with a security station to get people in, or time, right? You come in at 7:30, 8 o'clock, 8:30, maybe we got to stagger people more.
Absolutely, and that is one of the recommendations is in terms of staggering. But you see the dilemma in terms of, these programs have to be tailored to the needs and or the necessities around a given building or a given client. And so if you take in a high rise where you might have 3 or 4 different companies in there, your particular company may do it one way, another company may do it. So it's going to be incumbent upon the building management to say, okay, here's the process we're going to use by which we will allow people to enter and maintain social distancing. So it is more challenging. So I guess where it goes is the issue, one of the questions that was asked, well, what effect does the governor's opening business up? It's really going to fall on the employers themselves, because even though you've opened things up, until people are comfortable, and that they feel that there's a system that's going to work and make sense, I think we're going to find people are going to be uncomfortable.
And I've been reading some of that. Forbes ran an article this morning about how Georgia opened up its restaurants. How did day one go? And the thesis of the article was essentially that nobody went anywhere, except the tried and true who absolutely could not miss their coffee break or their coffee group. They showed up, but that was about it. So
it's a tough thing.
It kind of falls in the category of just because you can do a thing does not necessarily mean you should do a thing. And employers are going to have to be cognizant of all the moving parts. So we've talked about kind of coming back in phases, maybe as percentage of workforce, rethinking logistics. What else should an employer be considering as we continue these conversations about returning to work?
I think it's critical that they educate their workforce, and you educate your workforce on what your plan is, not what they think, because the employees want to know, that there is a plan, and they need to know and want to know what their role in this is. Okay, so is the plan to wear a mask? Okay, great. Do I have to wear the mask once I'm in the office? If I'm in my own office, as opposed to a cubicle, can I take my mask off then, or do I wear the mask all day while I'm out and about within the office setting?
What's your recommendation?
I was asked that question yesterday, so that's the reason it's one that's fresh in my mind. If you're within your own office space, it's like in your car. You don't have to wear your mask in your car. Now, once you're leaving out of your office, and I'm saying an office with a door and it's contained, right? Not office in a generic sense. If you're walking within a group, or walking past people when you're going to, the social distancing piece cannot be maintained. You really need to have a mask on until with true penetration in our communities. And as that is adjusted, as the risk is adjusted downward, and more people now have been exposed, and we see the herd immunity component coming up, then I think we'll be able to take the mask off and do the other things that return to a more normal life. But let's face it, life is not going to be the way that it was before. There's not a magic date that you're going to be able to say, okay, effective May 1st, go back, live your life the way that you did before, and not face risk as a result of that.
Because we have lengthened, we traded the spike for a longer curve.
Absolutely.
And so it's a new normal, not back to the old normal.
Absolutely.
What about sanitization? Is it overkill or unreasonable for an employer to be putting hand sanitizer, all over its office complex, if you will, or should employers be thinking about those kinds of details? Different chemicals for the cleaning crew, those kinds of issues.
Well, I think that it is proper hygiene is the appropriate thing to do anyway, whether we're in a pandemic situation or not. It's the right thing to do. We should always be thinking about hygiene. That said, we could flip the question and say, look, from a risk mitigation perspective, what risk would an employer face by not doing this? And if an employee, because that's one of the questions that I have, I'm waiting to see what OSHA's position is going to be on this, as well as what the federal government's position is going to be on. If someone is allowed, if employers allow employees to come back to work, and an employee becomes ill as a result of contact with another worker, and there weren't appropriate standards put in place to mitigate this, what sort of liability do they incur? Number one. Number two, is it a workers' comp or worker compensable sort of illness or injury?
So we actually covered that on this program.
I'm sorry, I missed it.
And yeah. So it varies state to state, but especially for the employers here who were not with us on that program, there is most definitely in some states a compensable injury under work comp if you contract it at work. That one of the difficulties will be proving that you got it at work. But if you're observing proper social distancing at home, and somebody at work had it, and you were in close proximity, and employer didn't take proper steps, that there's a pretty decent case that it is a work comp compensable injury. And I had questions about OSHA as well, about the extent to which it's a workplace safety issue, and how is OSHA going to view it? So there's definitely a concern there. It sounds like we're waiting on guidance. We don't have specific guidance from OSHA, but I'm betting we'll get something that suggests you got to be smart about this, folks.
And I think you're right. You have to at least do the basics. And there are certain industries that I think are really going to be challenged as a result of this. You take, for example, I'm looking at your hair. It looks a little longer than what I remembered being. And I'll tell you, I've had to resort to, for the first time in my life, I had to cut my own hair, and that was a really common experience and frightening, actually. But going to the barber, or getting your hair cut, the issues of hygiene around that are very critical. Or, for example, and this is one that really kind of surprised me on, not only on from the White House and the White House position on returning people back to work, but some other areas as well, like in Georgia, the reopening of gyms, because of the issue of proximity and equipment and, the need to clean those, this is critical. And unless you have
frequently,
unless you have a model that is really, clear on this and is based on some sort of testing, giving people a sense of confidence around that, I think is going to be challenging.
Which introduces another issue, and that is, particularly if you're in a consumer-facing, a B2C type of business, their optics to what it is that you're doing, and that should be considered as well. So when we've got just a few minutes left here, so bringing people back in phases and screening people as they come in, rethinking your logistics, educating your workforce, any other kind of bullet point items that employers should take away to say, okay, this is one of the things that we need to be talking about internally before bringing people back to work.
And I think that the last, but really is not, is as important as the other, is the ability to be flexible and to understand that the science around this is evolving and is changing, and to be willing to change your recommendations based upon that, both up and down. So if we find that the risks are coming down, the ability to do that, but to articulate that not only to your employees, but also to your potential customers, to say, look, we thought that we were going to be able to open because of some things that we've learned, we think the most prudent thing to do is to not. Or, the counter position is, hey, look, we now see that it is safe for us to open the restaurants, and to where we were limited to 4 per table, we can see that we can go now to 6, and the distancing model is showing something different. And so we want you to know that we're on top of this, and we're going to remain on top of this, because that's the part of the psychological aspects of this thing are as important as anything else. People want to know that they're safe, and they want to know that they're in an environment where the business owners are doing the right things.
So I just, having worked with lots of leaders, having been coached by other leaders, the psychology of leadership that you touched on just now is hugely important. And what you said was, be willing to change. There is a tremendous pressure to keep doing what you're doing, because you don't want to appear to be waffling or flip-flopping, to borrow from the political arena. Whereas you and I would talk, and like, flip-flopping is perfectly acceptable if there's new information.
Absolutely. But you have to articulate that information. You have to tell people why. And, a great example of this, because I've had people who've said, have asked me the question, well, was all this really needed? Was this real? And, particularly folks here in Houston, because we have been, believe it or not, we have been blessed in Houston in terms of what could have happened versus what has happened. And I will tell you, early on, talking to colleagues and very close friends in the medical center, we were quite concerned about what would happen. And if you want to look at it, if you look at what took place in New Orleans because of the Mardi Gras, and I think virtually everyone agrees that the Mardi Gras was the nidus, of this. Had we not taken similar action as it related to the rodeo, and and continue with the rodeo, because the issue of social density was so high at the rodeo that I suspect, had they not done that, as unpopular as it was, and it was incredibly unpopular, that we would probably have been looking at numbers in Houston very similar to what Louisiana is facing.
And so absolutely, which is good to hear that that the sacrifices people are making have resulted, as near as we can tell, in a positive result. So that's really good to hear. We have a couple of questions here from some folks, and Miss JC Lee, if you are near a microphone, we're going to put you on the air here. If you're not near a microphone, we'll go ahead and read your question out loud, but let's see if we can get you on the air. Miss JC Lee, what's your question? There you go, JC.
Hello,
on the
can
air.
you hear me?
You're on the air.
Oh, okay, perfect. Hey, Dr. Wells, hope you're happy and healthy.
Yep. Good to hear you. I liked your the video you sent out.
Oh yeah, that I shouldn't have posted that on social media.
That was great.
My question is, should at-risk people return to work even if they aren't showing symptoms?
Well, the question is really twofold. It's you know, how do we define at risk for that person? You know, and if we're talking about an individual, let's say that they have recently undergone chemo, or they're undergoing chemo, or otherwise on some immune that produces some immune compromised nature within their body. It probably, to the extent that they can continue to work remotely until we get on the other side of this, it may very well be best for them to not, and to continue the social distancing. If they have to, then making sure that all the appropriate precautions are taken. But that's a conversation and a discussion that I would advise them to have with their treating physician, who can best assess what their real risks are at this point.
So excellent question, and it actually factors into kind of the four things that we've talked about in terms of, you know, bringing people back in phases. One of the considerations should be, you know, the extent to which you're asking somebody who is immunocompromised to come back to work, and seeing what you can do as an employer to you know, work around or work with that kind of a situation.
Absolutely, because ostensibly that group, the people at higher risk should be one of the last groups that are allowed back in.
Real quick, so we're talking about what at risk means, and we've talked about immunocompromised, but has the data shown us anything new about, you know, age or race or gender as far as, you know, putting someone in the category of at risk?
Yeah, you know, that's very interesting, because, you know, when this thing first popped up, it was, well, this is a disease that just affects the old folks, right? You know, and since I'm rapidly approaching that old folks category, you know, it's something that kind of got my attention. But I will tell you, now we're seeing cases cropping up in individuals who are in their 20s, 30s, and you know, quite severe cases. So that's not that. We also see the people who have issues of pre-existing conditions. Diabetes, obesity is a fairly large harbinger of it. People who have a pre-existing problems with emphysema or other lung-related conditions also are at greater risk. But there's another category of people who were perfectly healthy. I mean, had no problems at all, worked out every day, somehow came into contact with it, ended up in intensive care units on respirators, and unfortunately, in some cases, didn't survive the disease.
Yeah, so it definitely goes to the we don't know, back to what we were talking about kind of at the beginning of the hour. We just don't know. And so to recap, or to highlight your last point, be willing to change, because things will change. We've reached 11 o'clock. I want to be respectful of everybody's time. Dr. Wells, thank you so much for coming on the program today. Thank you, everybody, for your participation. I especially want to extend a special thanks to our producer, Kendra Lefevre, our research team, Marcus Mahena and Christy Vanderwater, our advertising director, Aaron Richard, our stenographer, paralegal, and Gal Friday, Dana Sturkle, and all those who helped put this together. Thank you, everybody, for your time, and stay safe and stay sane.